detail of how we conducted it, why we conducted it, some of the outcomes. But to begin with, I think it's important to introduce, I guess, myself as your speaker, who's taking a bit of your time this afternoon. So my name, as I said before, my name is Rodrigo Stein, Director of Health Equity and Strategic Partnerships here at La Clinica del Pueblo. My story is born in El Salvador during the Civil War years in the 1980s to a Honduran mother and Guatemalan father. So if Central America could be or remain the country as it once was, I would probably identify as a Central American. Due to my father's job, I moved a lot when I was a young kid, and sort of continued that trend into adulthood as well. So I've lived in over 10 countries. However, none of those have been due to dislocation or forced migration, which is a shared, which is the story of a lot of our community members and most of those who receive services here at La Clínica del Pueblo. So also before working here at La Clínica, I had a lot of experience in sports-based youth development, which was sort of my opening into public health. And how I arrived at understanding what I had been doing for years was actually public health, and now I'm fully involved in everything related to public health. And as I said before, I've had the opportunity to receive education in Canada, UK, and the US. So that's a bit about me. So what are the objectives of our presentation today? So provide a bit of an overview of the Latino population living in Prince George's County, the health barriers they face, also emphasize the role of FQHCs in promoting health within the county. And I guess the most important, or like why, is highlight La Clínica's participatory rapid appraisal approach as a form of community-based participatory research that can complement efforts done at the local health departments and other organizations in understanding perceptions of health conditions, barriers, and collective solutions to overcome them. Before I begin with the presentation, any questions? I'd like to make sure. Please, as I go through the presentation, please interrupt me if I'm going too fast. And also at any moment, if you have any questions, I don't know, Taylor or Abril, my colleague from La Clínica, is here as well. If there's any questions in the chat, just please let me know. Perfect. Uy, what happened? There should be an image there. Yeah, can I stop sharing? Because there should be an image. I don't know why. Anyway.
I was seeing images. I see a map.
The image? It should be a map of Central America.
Yes.
We see it.
You see it? I don't know. It doesn't show up for me, but if you all see it, that's what matters. So, when we talk about Latinos, I know we're talking about an expansive region of the world, 24 countries, each with its own idiosyncrasies, histories, and relationships to the US. So I think it's important. And also the term Latino, what does Latino mean? Who is Latino? Who would belong to Latino? I think that is not the purpose of this conversation. It is a very interesting conversation, but we want to narrow the scope of the conversation for our purposes. So in the region, there's over 900,000 Latinos being, as I'm using Latino, and all of those who were born or have direct lineage to someone from Latin America. Latin America being an expansive region from Rio Grande to Tierra del Fuego, 24 countries, a lot of Caribbean islands as well. So that is a very expansive region. However, who are the Latino immigrants in our region? And those are primarily immigrants who are coming from Central America, primarily El Salvador, Honduras, and Guatemala. And they represent the largest Latino immigrant concentration, the largest Latino immigrant in the region. And just behind New York and LA, they are the third largest concentration of Central American immigrants in the country. So the reasons why people migrate, I'm not going to narrow it to one only. There are multiple reasons: family reunification, economic improvement, displacement. There are a number of reasons why people migrate and relocate. However, there is a history that can be told, specifically for Central American migration, and and it can be really tied to events happening from the 1980s onward. So, as some of you may know, during the 1980s and prior to the 80s, there were movements all across the world, not only in Central America, but also for self-determination, recognition, land redistribution, wealth redistribution. And as such, the United States had a firm policy of containing communism that led to counter insurgencies or counter movements for the revolutions that were happening across the region. This essentially resulted in civil wars happening and breaking out in Honduras, and Guatemala, El Salvador, Nicaragua as well, and Honduras being sort of the hub where the counterinsurgency was being deployed across Central America. This generational trauma, which also happens before, is deeply tied with the migration flows, as during the Civil War years, the flows of people coming to the United States were not necessarily afforded the same asylum status that people fleeing the communist regimes from Cuba, for example, even from Nicaragua, were being afforded the same asylum status as the people fleeing primarily Honduras, from fleeing El Salvador and Guatemala, were fleeing from friendly territories according to the United States. This resulted in a lot of these populations not being granted the same asylum status or access a transition to an immigration status that could be then be recognized. Also, it's important to note that despite the increased rhetoric that we're hearing right now from the Trump administration, that nativism and xenophobia that has been ramped up right now is not new. It has been a consistent policy for years. For example, the IRCA Act signed by President Clinton in 1996, which included the 287G clause, conflated what is an administrative procedure, which is adjusting an immigration status, with a criminal status of crossing the border illegally or being out of status as a criminal act instead of an administrative requirement. Also, we have to remember that President Obama deported 3 million people during his administration. So, and if we even go farther back, nativism, xenophobia have been pretty consistent across the history of this country, with right now being ramped up. So I just think it's important to ground ourselves in the history, who we're talking about, and the reasons migration happens. Any questions so far? Perfect. So, what is the health status, access to healthcare barriers of some of these populations? So it's important, if we focus on PG County's population, we know that about 24% of the county's residents identify as Latino. As I said before, most of these being Central American origin. They represent the second largest demographic next to the Black African American community. And there are majority in areas like Adelphi, Brentwood, Riverdale, and Langley Park. So what are the risk factors that we see among this community? High blood pressure, obesity, all risk factors closely tied with chronic conditions, but also in other areas such as mental health, number of average days of reporting poor mental health. We also see high prevalence among the Latino community. Additionally, for the health status of the community, we also understand within the immigrant community that, like 8% of the United States, which is limited English proficient, PG counties is 7%, so very similar. However, in those distinct zip codes like Adelphi, like Langley Park, which I just mentioned before, we have areas in the county that have 3 times the average of limited English proficiency. So adding an additional barrier. From the experience that we know as a culturally sensitive healthcare provider, and the experience or the fundamental need of having culturally and linguistically accessible service, the importance of having not necessarily consistent access to bilingual professionals, but at least highly trained medical interpreters is key to promote good outcomes. Furthermore, we know that variations based on health insurance, based on our immigration status, ultimately determine a lot of who gets access. We're fortunate to be in a jurisdiction like the District of Columbia, which offers the DC Alliance, which is a local health insurance program for those excluded from Medicaid. Also, we've done expanded some victories in the county and in the state through the Healthy Babies Equity Act and the Access to Care Act. Still fighting for the PG CARES Act and Health Assures at a county level. But it's important to ground ourselves that the immigration status of a lot of individuals, even those lawfully present and with recognized immigration statuses, are restricted from certain access to Medicaid, particularly. For example, TPS holders are not eligible for Medicaid as their status is renewed every year. They are available for ACA subsidies and plans, but not Medicaid. So in addition, the types of jobs, the income and occupation that a lot of our community is engaged in restricts or forces people to make difficult trade-offs, even when employee-sponsored healthcare is offered. So the wages are so low, rents are so high, and the cost of living is so high, plus remittances that must be sent over back to our countries of origin, put people in difficult trade-offs where maybe healthcare is not the priority. So even when it's offered at an employer level. Questions so far? Oh, perfect.
Yeah, I have a question. This is Greg Taylor again. So you talk about the population of Prince George's County is roughly 225,000 Latinos. And out of that, you said 24% are uninsured. And so how are they getting care?
So there's a range of options, including the services that we provide at an FQHC. A lot of it is uncompensated care from emergency rooms as well, but FQHCs, we have a mandate to promote healthcare to all, regardless of their ability to pay.
So you are addressing that 24% of uninsured. You have a way to address that, to mitigate it.
I wouldn't say we are addressing it for all, and that's why we need expansive solutions and county solutions as well, and that is the reason. But for example, through the Healthy Babies Equity Act, pregnant women and their infants up to 4 months postpartum are able to receive prenatal and postpartum care. Right now, with the Access to Care Act taking into effect, I believe, in 2026, they will be able, all persons, regardless of immigration status, will be eligible to participate in the market exchange to purchase health insurance. And those are the mitigating factors and the services that we as FQHCs provide step in to cover. So, but that's a good question, yeah. And I think that's from the state. That's not only PG County.
Okay, so when you say that 24% is from the state.
The state of Maryland is.
Okay, I got you. I was thinking that 24% of the 225,000 Latinos that reside in Prince George's County, and out of that, 24% are uninsured. But okay, I see it now. It's Maryland. Okay, thank you, sir.
Perfect. No, you're welcome. So just to sum up, immigration stressors and low income combine and just act as reinforcing or enforcing determinants of health. Both federal and state eligibility policies disproportionately exclude immigrants with varying immigration statuses from safety net services. This is not only a documented versus undocumented issue. People with documented and legal statuses are also excluded from a number of safety net services. Then once again, the financial constraints. A lot of the population works in many low-wage jobs without employee-sponsored insurance or must prioritize basic needs. And as I said before, with the language access, there is a routine experience of discrimination, whether interpretation is not provided, even though that's a requirement under Title VI. There's a number of stories where the encounter with the safety net systems and healthcare is not culturally and linguistically responsive. So what is the role of an FQHC like us? We're federally mandated to provide comprehensive primary, oral, and mental health substance use care to all of individuals, regardless of their ability to pay. We're a critical part of the healthcare safety net, serving over. Sorry, I saw a comment from. Sorry, I see a comment. I don't know if. I think from Sharon. Sharon, please jump in.
I just wanted to clarify that undocumented and people with previously excluded immigration statuses can now purchase on the marketplace, but they are not eligible for subsidies, which means that they're paying full freight for the cost of insurance, which is really prohibitive to many people who might seek to purchase care.
Yeah, absolutely. Thank you so much, Sharon. And sort of building on what Sharon was saying, so safety net providers like La Clinica, which and other FQHC partners, we do have some capacity and reimbursement limitations for specifically uncompensated care. For example, for us, hiring and training, identifying fully bilingual healthcare providers. So even though we do exist, we're still operational, we struggle to meet the high demand of such a population in need. So the history of La Clinica itself, it started, as I said before, you can trace the history of the organization with sort of my first slide. Starts in the 1980s with the first influx of Central American refugees fleeing the armed conflicts in Central America. It starts out as a program here in the District of Columbia as part of Carecen, which I know a lot of you maybe have heard of. The organization grows to an extent where it is able to become a standalone program in the 90s, becomes a 501c3, and since 2007 receives the designation of FQHC, and we've been operating in Maryland as an FQHC since 2016. So our model is truly to provide an integrated approach, prioritizing both primary care, mental health services, with the added wraparound services provided through our community health action, health equity, and language access units, which community health action promotes not only public health campaigns and health education strategies, but also is our strategy to be grounded in the community through community health workers. And our health equity and community partnerships works around mapping barriers, sort of what I'm going to present in a bit. Also addressing some of the policy and advocacy, and also the deployment of medical interpreters across the region. So we see over 4,000 people, 3,000 of those are Maryland residents. So the majority of people that we serve are Maryland residents. Some of them receive services in DC, but most of them reside in Maryland. And these are our sites. I have a primary care site in 15th Street here in the District of Columbia. Our Prince George's County site is in, I was going to say PG Plaza Metro, but I think it changed right now, right? I can't remember what's the new Hyattsville crossing. They changed it. The Green Line. They changed. Anyway, the name, the PG Plaza Metro, now with a new metro station name. I can't remember it right now, but that's where we are located. And we have 3 based school mental health providers, Mi Refugio, but I'm just showcasing our flagship, which was opened in Northwestern High School. So I'll proceed now to explain sort of like our project on, around understanding the perceptions of health conditions and primary barriers using a rapid appraisal. So what is a rapid appraisal? First of all, it's a form of community-based participatory research, which essentially has core elements such as collaboration, active community involvement, not only by soliciting the community's health priorities, but the community itself develops or recommends the interventions necessary. It is essential that its methods and strategies equalize the power dynamics instead of a facilitator extracting information. The group co-creates the information, and there is an element of even handing over power. For example, as facilitators, we don't write responses on behalf of patients. We don't even tally on behalf of patients. We let the flow really be devolved back to the community and empower them. And I'll explain what I mean before. The method that we used has been applied across disciplines and the social, I was going to say social science, yeah, social sciences, but also across interventions in housing, with a lot of resource poor communities to address issues such as climate change, urban violence, informal economy. And it is not unique to public health per se, and it can be adapted across disciplines. It's important that the approach really is set in being purposeful in segmenting a number of affinity groups that have shared characteristics, and then tally those totals to get a real understanding of what is going on in the community. So what we tried to, with those principles in mind, we set out to understand what were the most common health conditions that the community was perceiving affecting Latino immigrants in the District of Columbia, Maryland, and Virginia, and what were the significant social barriers that were preventing that community from improving or enjoying better health. So what is the process that we followed? La Clinica benefits, as I said before, from a health education, its community health action department and other strategies that as part of their core components, it is to convene groups across shared health conditions, whether that's chronic conditions, living with HIV, etc., and promote lifestyle or behavior change groups. So we're able to recruit among those different affinity groups that belong to people living with certain health conditions, or even being part of our health promotion or promotores de salud group. And we're able to recruit based on those affinities, which gave us a good representation on age, living with certain gender, living with certain health conditions, and jurisdictionally as well. So we hosted 7 community conversations. All the conversations use the same data collection tools and ask the same questions. And since all groups use the same questions and data collections, you're able to create clusters to interpret the data through content analysis and then quantify totals. So the method that we use to collect what was the most common health conditions and barriers is our listing and ranking method, which is really a manual process, as you can see from the photo right there, of community members listing what are the health conditions that they're experiencing, and then assigning 3 votes, 3 being the most pressing, 2 the second most pressing, and 1 the third less pressing. And then we would follow through what we call a causal flow diagram, which allowed people to dissect what is the cause of that major health problem, and then do the listing and ranking process again. And once that process was completed, we were able to triangulate results with other sources to understand what we were finding is being identified across the literature, and if we were missing anything. I won't go into too much of detail in that, but yeah, the content analysis is done through we were able to synthesize what we were finding by matching the health clusters with the WHO social determinants of health framework and their mortality database to match what we were seeing and cluster it around those conditions. So what were the results and outcomes? From the participants, the majority were female. The age groups that were most represented were all working adults. We did have a group of, as I said before, in our school-based program, which is represented by 15 to 21-year-olds, but the majority of people were of working age, or working adults, female working adults. No surprise, their countries of origin. As I said before, the PRA just validated that the majority of people in our region are from Central America, from El Salvador, Guatemala, Honduras. I know we're seeing a higher amount of Venezuelan immigrants. However, the majority still are Central American. In terms of the zip codes most represented, we had 2781, 2782, and 2783 as the most common PG zip codes represented. And what were the key findings? Well, the community perceived mental health to be the major health concern affecting their community, followed by chronic diseases, and then substance use, and the barriers that prohibited the community, or the community perceived did not allow them to enjoy better health or improve their mental health or chronic conditions, were tied to income and occupation, access to health services, immigration status, access to food, and language barriers. These are just some quotes to highlight what the community was telling us or what participants were saying, tying discrimination, tying discrimination to depression, right? Like the experience of discrimination was a barrier that did not allow people to improve from feelings of depression. Also, immediately acknowledging that poor diet is not necessarily bad choices, but a problem related to heavy work schedules and precarious work. There's also an acknowledgement and recognition from the community that it's not necessarily the lack of jobs or lack of opportunities, is those jobs are exploitative and don't pay what the cost of living demands or the situation requires to be earning. And also an immediate recognition around the neighborhood and conditions that surround their communities. Overly exposed to fast food environments, and also acknowledging the income disparities between who can afford to live where, who can afford to shop places. So there's an immediate recognition of what we would call the social determinants of health. I want to make sure I'm not missing anything, if there's any questions.
No, we're just working through some tech issues, but no questions in the chat yet.
All right, perfect. So once we started comparing what we found with secondary sources, so for example, we compared what we found in our needs assessment with, for example, the most recent 2023 Montgomery County's Community Health Needs Assessment, and also the 2022 PG Needs Assessment, and they were very similar. For example, mental health, obesity, and diabetes were the top concerns among Latino respondents in the Montgomery County's Community Health Needs Assessment. In Prince George's County, through the health needs assessment done here, mental illness and obviously, I believe COVID was the first one in that year, but also mental illness and substance abuse were ranked second, third, and fourth most common conditions as reported by the Prince George's County survey, and it sort of resembles what we found ourselves in our rapid appraisal, with the community identifying mental health, chronic conditions, and substance use as the most pressing health conditions affecting the community. Once we started triangulating a bit better with like additional sources, once again, the rapid appraisal told us that the community identified income and occupation as the #1 barrier. And once we identified other sources tracking the community, we see the income disparities affecting Central American immigrants. So I believe the most recent, and I might be wrong because there's so many household income figures from different sources, but the most recent PG median household income, I believe, is 125 or 101. I don't know. I would love anyone to correct me on that one. But once you trace it down, you do the household income according to the Migration Policy Institute. It is 70,000 the median household income. Once you do the aggregated even further among Central Americans is 55,000. And the community health needs assessment, for example, in the resident survey, identified that all the Spanish-speaking participants who participated in the community needs assessment of PG County reported an income of 49,999. So there's a vast income disparity, and that demographic of Spanish-speaking residents, I complemented with such a high percentage of women participating in a rapid appraisal. And as indicated, once again, from data from the 2022 health needs assessment from PG County, which reports the highest poverty rate of them all, sort of validates income and occupation as why it's the #1 barrier for a community, and also was validated by the high participation of women in our needs assessment. So as you can see from a very participatory approach, very community-led participatory approach, our figures resemble a lot what local health departments are showing, but with the added value of more participation from the communities that sometimes may not feel that may feel intimidated by participating with local health departments and other agencies. Once again, if you compare what we found in a rapid appraisal with access to food as being a significant barrier, and you compare it to the U.S. American Communities, the U.S. Census American Community Survey, there is food insecurity at 8% for all Latino households, and we found that 11% identified food access as a tremendous barrier. So there's a similar figure that we found and what the U.S. Census found. So, any questions? And I want to make sure I still have enough time.
Yeah, we are all good time-wise. Does
Okay.
anyone want to unmute and ask any questions or any reactions to the data that Rodrigo just presented?
Good afternoon, everyone. I apologize for my tardiness, but I'm not at all surprised by the data that you're sharing with us. As a matter of fact, what we have been experiencing here at the Black Mental Health Alliance in regards to the calls that we're getting for assistance, it bears out exactly what you're reporting. I want to thank you for this. I'm so glad that I've even been able to get a part of this afternoon because this is very good information.
Thank you so much. So, and as I said before, the method that we're using does not stop at identifying barriers and identifying conditions, but it takes it a step further, and it works together with the community to generate concrete recommendations on how to move forward. We also know that it's also specifically in this environment, it's not up to, we can't really expect the communities to, how do you call it? There's an element of safety, right? Right now, an element of safety has to be taken into account. So we work in coalition, working to advance these policy recommendations. And I'll show you the sort of the process of how we took it to working with a cross-sectoral lens to advance what we call health in all policies in the public health world, because these are ultimately socially determined and not necessarily an issue with the health system, but also the living conditions that surround us that need adjusting. So sort of the process that we followed, as I said before, the first, that is a short timeline of the process that we followed. From July to October, we did our community-based conversations, analyzed the data from October to March, from 2023 to March 2024. And once the data was clear to feedback to the community, we re-invited them to present what they had told us, what we had worked together to identify, and sort of like the data that I just presented to you all, and also generate some recommendations of where we could work together. Those recommendations were then further validated in another setting where we invited cross-sector partners in August to finalize sort of the recommendations. So the first process was identifying the problems, which happened in 2023. The second step was with the same community, generate policy recommendations. And the third process was validate those policy recommendations exclusively, not only with exclusively with cross-sector partners, but also public agencies from the District of Columbia. This is our first Prince George's, but so far with DC, we shared the data. So what were some of the recommendations? I tried to be specific to PG County right now because the policy recommendations would have not necessarily applied to it would be for the District of Columbia. But for example, right now, we know that there was policies to ensure fair wages by increasing the minimum wage. That would be incredibly helpful. I think it passed and will take effect right now in July 2025. But also, if there's opportunities to increase workplace rights protections or grants that familiarize employers with or employees with their own rights, that is something that was also recommended here in the district. Another policy recommendation that was generated from these conversations was the idea to establish programs like the Montgomery County's Welcome Back Center. I believe the Prince George's County nor the District of Columbia has something similar. If any of you all know of something similar, please let us know. But it's essentially a navigation center that allows internationally trained professionals in the health education fields to orient them how they can validate their credentials and also, and at the same time, reintegrate themselves into the workforce with their in their field, and also increasing the culturally competent workforce that is more and more needed, but also address some of the language barriers. The access to healthcare that was proposed in the district was parity between DC Alliance and Medicaid. However, here we know that protect Medicaid access, specifically for the Healthy Babies Equity Act, is key. Also, identifying a local reimbursement mechanism through our PG Cares program, and also protecting the health assurance program at the county level are key, but also make sure that once the Access to Care Act becomes fully operational, that even though there are no subsidies, that we try to navigate people for insurance. And right now, we know that at a state level, Maryland House Bill 1473 ensures equal access or language access to public services for individuals with limited English proficiency and individuals' disabilities. So all that to say that, and to conclude, and those policy recommendations are live, and I would love to hear if any of you all know of any policy recommendations that we should be putting out or tracking that address some of the barriers that our community identified, from income and occupation, access to health services, language access, access to food, etc. To let us know and invite us to any of your coalitions. We would love to be a part of that. So just to conclude, the rapid appraisal and using the methodologies grounded in community-based participatory research and implemented by trusted organizations like us, like La Clinica, it complements the valuable data that local health departments are already collecting. Like, the health departments are collecting a wide range of data and big data, but we believe that the data that La Clinica can capture, or organizations like us, complements some of, or gives more life to some of that data that health needs assessments often miss. Internally, this data has allowed us to improve the type of cross-sector partnerships that we are trying to identify and strengthen, and also made it more visible across the whole service provision internally at La Clínica of the importance of health-related social needs. Once again, the data can also be used to confirm that immigration stressors are a determinant of health, and they indicate a need for comprehensive approaches that extend merely, and as a healthcare provider and as who have health access in the front of all their policy and advocacy strategies is not enough. Like, we need these comprehensive approaches that to improve the health of the community is beyond just health access. And also it demonstrates why the FQHCs were mandated to conduct needs assessments as well, but investing more than just a cursory approach of analyzing service utilization. Once it's that we should invest as organizations ourselves to really use some of these methods to understand what our community is needing. So, and that's my presentation. Thank you so much. I'm open to questions.